Thank you for joining the webinar. Maybe as you sign in or as you come in, you can put in your comments who you are and where you're coming in from and what your interest is in women's health in the comments so we can share who's participating in today's webinar. We'll just give it a minute or two. We've got a lot of people joining. Thanks, Alyssa, for getting it started. Great. And as people join, if they could continue just to put in their name and where they're calling in from or where they're viewing this from and their interest in women's health research, I think we'll get started with this. My name is Kate Powis, and I'm based at Massachusetts General Hospital, and along with Maria Alcaide, who is based at University of Miami, we're the co-chairs of the Inter-CFAR Collaboration for HIV Research in Women. And we're really excited today to hear presentations from Dr. Andrea Ciaranella and Dr. Sylvia LaCourse about the latest in guidelines. And what we'll do is we'll have each person present for 20 to 25 minutes, and then we'll open it up to group questions. But feel free, as something comes up during the different talks, to put questions into the comment section, and we'll be monitoring those and giving the speakers an opportunity to know what questions you might have. So with that, I'm going to turn it over to Maria to introduce our first speaker.
Thank you so much. Thank you, Kate. Our first speaker is Andrea Ciaranella. Dr. Ciaranella is an associate professor of medicine at Harvard Medical School and an infectious diseases physician at the Massachusetts General Hospital. She serves as director of the Perinatal Infectious Diseases Program at the MGH and director of the program in Health Economics and Modeling at the Harvard University, CFAR. She's the co-chair of the U.S. Department of Health and Human Services Panel of Treatment of Pregnant Women with HIV Infection and Prevention of Perinatal Transmission, and has served as technical consultant for UNAIDS and WHO about simulating modelings and cost-effectiveness related to pediatric HIV and mother-to-child transmission. And we are very happy to have you here today. And Dr. Ciaranella is going to talk about the U.S. perinatal HIV guidelines, key updates for 2024. Thank you so much for being with us today.
Thank you very much for having me. It's a pleasure to be here. Can you all see my slides okay? Great.
Yes, they look great.
So I have no financial disclosures. As was mentioned, I do co-chair the perinatal guidelines panel, and so we would recommend welcome any feedback that you might have on how we could make these guidelines more useful and more helpful to all of you in your practices. So we'll start today with a case and go over some brief background on HIV and pregnancy. And then I'll give some updates on our current ART recommendations, including talking a little bit about the categories of recommendations that we make and the data that we need to support those. And then some updates on our new infant feeding recommendations. So we'll start with a 33-year-old woman. She has well-controlled HIV on bictegravir, emtricitabine, tenofovir, alafenamide. Her CD4 is high in the 600s, and her viral load has been undetectable on that regimen for the past 3 years. She comes to clinic and she's excited because she's just learned that she's pregnant, about 8 weeks. It's a wanted pregnancy. And you wonder, should she make any changes to her ART? And she asks, is it safe to breastfeed? How should you advise her? So we can pull up a little bit of a poll for this first question. Should she make any changes to her ART? And some of the potential answers are yes, no, she should remain on her current regimen, A. Yes, she should change the anchor drug to dolutegravir. Yes, she should change the anchor drug to boosted darunavir. Or yes, but she should change the TAF to TDF. So we'll give people a few minutes to just indicate what you do in the chat. And I actually am trying to figure out how to see the poll results, but you have to freeze them first. Is that it, Meral?
They have attendees are able to see them, so they're answering the poll question right now.
Okay,
then-
maybe you could just give
Yep.
me like an indication of what seems to be winning.
So no, remain on current regime is winning right now.
Okay, great. Okay, let's go to the next question, which is it safe to breastfeed? How should you advise her? And so we could do, oh, now I can see them. Thanks. We could do A, yes, breastfeeding is recommended now. B, no, formula feeding is recommended. Or C, something like, what does safe mean to you? And some shared decision-making. I suspect this one, if you're a good test taker, is pretty easy. Maybe we can see the results and go on to the next one. Great. Okay. So in the era prior to widespread availability of ART, we know that the risk of transmission of HIV from a pregnant person to her baby is about 25% during pregnancy and delivery, with breastfeeding conferring an additional 15 to 20% risk, depending on the duration of breastfeeding. The ACTG 076 trial in 1994 was the landmark study that told us that AZT in pregnancy could reduce that risk from 25% down to about 8% in non-breastfeeding settings. And since then, we've really seen a very steady and dramatic decline in the number of new infant infections occurring in the US. Now it's just about somewhere between 25 and 40 infants who acquire HIV at birth each year. This allows us to have that success build on the success of another major paradigm, which is the idea of U equals U, or undetectable equals untransmittable. And we have really outstanding data to support the U equals U claim in sexual transmission. So now with data from more than 125,000 condomless sexual encounters with phylogenetic data available, there were no linked transmissions if the partner with HIV was on ART and had a viral load under 200 for at least 6 months. For perinatal transmission, I think we can also say that U equals U, but the data set is much smaller. So among more than 5,400 pregnant people in the French perinatal cohort, there were no transmissions observed if people had an undetectable viral load from the time before conception all the way through pregnancy and delivery. And unfortunately, I don't think we can say that U equals U for lactational transmission. Again, we have a pretty small data set, about 4,000 people, and it seems that the risk is very low, about under 1%, but not quite zero. And I think it remains to be answered whether there is a scenario in which U equals U for breastfeeding transmission. So our goals for ART in pregnancy are really early and sustained virological control. And ideally, a situation in which viral load is undetectable from the time before conception, if you meet someone then, and throughout pregnancy and at delivery. So let's turn now to the ART recommendations that help us try to achieve that goal. Our US perinatal guidelines make 5 different categories of recommendations about medications. And those are preferred, alternative, insufficient data, not recommended except in special circumstances, and not recommended at all. And we offer these categories for each medication in each of 5 different clinical scenarios of people initiating or reinitiating ART. And we'll walk through those scenarios in a little bit more detail in a couple of slides. But I wanted to highlight the categories because they're different from the ones used in the adult guidelines, which are recommended for most people in clinical situations. So what data do we need in order to make these recommendations? In order for something to be a preferred drug, we need efficacy and safety data in non-pregnant adults. And we need pregnancy-specific PK data so that we can extrapolate those efficacy data to pregnancy. We also need pregnancy-specific safety data. And we usually require peer-reviewed data, so published in journal form. And we need at least 200 first trimester exposures in order to rule out a statistically significant difference in congenital anomaly risk for one medication compared to the general population. And we also just want there to be a favorable overall risk-benefit calculation compared to the other options that are available in pregnancy. In order for a medication to be alternative, we want to see efficacy in non-pregnant adults, but we can have limited, as long as it's favorable, pregnancy, PK, and safety data. And these data are often published in abstract form, but not yet in peer-reviewed journal manuscripts. Insufficient data usually applies to medications that are approved for non-pregnant adults, but where we have very little or no PK and safety data in pregnancy. Not recommended except in special circumstances. That usually applies to medications that are not recommended as first-line ART for non-pregnant people, but where people with substantial ART experience may benefit from either reinitiating these medications or staying on these medications, because we think that the benefit of maintaining viral suppression is an important thing to balance against the lack of PK or safety data. And then there are actually very few medications that are just not recommended at all. These are usually medications that have inferior efficacy or potentially serious safety concerns. So why do we sometimes lack the data that we need to really move medications up that hierarchy quickly? Pregnant and breastfeeding people are excluded from many clinical trials. And so as a result, we often only get data on pregnancy outcomes when drugs are used widely in clinical practice. And by nature, this leads to less robust data. So ascertainment is variable, definitions differ, measurement is often not reported. This can occasionally lead to harm caused by drugs that turn out to be harmful, but much more often it leads to harm from people not receiving drugs that could be beneficial to them. And we saw this with dolutegravir, where concern about risk for neural tube defects led many people of childbearing potential to lack access to this medication. And even when larger data sets showed that that risk was not greater than other medications, still many women are not given dolutegravir globally. And so WHO and many other agencies have called for the earlier inclusion of pregnant and breastfeeding people in clinical trials, and for the development of robust pharmacosurveillance systems so that we can collect better data when drugs are widely used. But I think, unfortunately, these are lessons we still have not learned well. And we saw this with COVID vaccination and COVID therapeutics, where pregnant people were excluded from trials. We saw this with tenofovir alafenamide-based PrEP, where women were excluded from the original studies. And so I wanted to call your attention to one really valuable resource, which we use a lot in the guidelines development process, which is the Antiretroviral Pregnancy Registry. And the website is shown here. This is a voluntary registry where we can submit information about our patients who are pregnant and exposed to any ARV, whether it's for PrEP or for treatment. And I would encourage people to please submit your patients to it, because we really do use this a lot in the guidelines process. It does take some time, though, for between the time of FDA approval until we get to that sort of 200 first trimester exposure threshold in the APR. This was a nice study by Bill Short that showed on average that gap is about 6 years. And perhaps because of this delay, practice patterns often differ from guidelines. I think a really important study by Kate Powis in the FACTS network showed that among pregnant people with HIV initiating ART from 2008 to 2017, fewer than 70% received medications that were considered to be preferred or alternative at the time. And I think this raises a really interesting question of whether clinical practice should inform guidelines or guidelines should inform clinical practice. But I think we really need better and faster data to help us move drugs up in the guidelines more quickly. I wanted to call your attention to this table 7 in our guidelines, and I'll walk you through it, but I think it's a valuable resource to have in your toolkit. As I mentioned, there are 5 scenarios for which we make recommendations, and those are shown across the columns. So the first is recommendations for ART for people who have never received any ARV drugs in the past and now are starting ART in pregnancy. The second is for people who are continuing ART when they become pregnant and they're on a regimen that's working well. They're tolerating it, they're suppressed. The third is people who've gotten ARV drugs in the past but are now not on them and are restarting. And that can be previous exposure for PrEP or treatment. And then the next is people who become pregnant on a regimen that's not working very well. They're not tolerating it, or they're not suppressed. And last is for people who are actively trying to conceive. And so for each of the classes of medication shown here are the integrase inhibitors. And for each individual medication, we make one of those recommendations that you saw earlier: preferred, alternative, et cetera. I just wanted to distill out the key recommendations for people newly initiating ART. These are the preferred and alternative regimens. So there's actually only one preferred anchor right now, which is dolutegravir, but many preferred backbone agents, including TAF, TDF, abacavir, lamivudine, and tricidebine. There are a lot of alternative anchors. So in the integrase inhibitors, bictegravir and raltegravir, in the PIs, darunavir and atazanavir, and in the NNRTIs, efavirenz and oral rilpivirine. And AZT is now an alternative NRTI. Just to chat quickly about bictegravir, because I think it sort of shows the trajectory of medications moving up the hierarchy. In the 2024 guidelines, for the first time, bictegravir moved from insufficient data to alternative. And that was because we had data from the APR on 324 live births with first trimester exposure. And the anomaly risk of 4.3% was within the range of the US population comparators. We also had data on pharmacokinetics and HIV suppression from 2 studies, again, Kate Powis Impact Ped 2026 and a Gilead study, both with around 30 patients. They actually had remarkably similar results. So compared, even though these numbers were calculated slightly differently in each study, but compared to people who were postpartum or non-pregnant, there was between a 56 and 71% reduction in drug concentration in the 3rd trimester. Importantly, all of the suppression rates were high, so 90 or 100% at delivery, and there were no infant transmissions in these small studies. Importantly, these drug level reductions are greater than the level of reduction we see with dolutegravir, for example. But they are all above the levels that are anticipated to inhibit HIV. And so because we had these PK data in mostly in abstract form, the panel felt comfortable moving bictegravir up to alternative. So our patient, though, would fall into this second column, which is people who are doing well on their current ART. And there, the recommendation would be to continue. Actually, any of these other drugs are preferred in pregnancy, except for the darunavir now has moved down to alternative. But there's a great value in remaining on a medication that is working well and not making a change in pregnancy. So let's turn to the infant feeding updates. For many, many years, we advised really strongly against breastfeeding. In 2018, for the first time, we had a new section on infant feeding, which noted that breastfeeding was not recommended, but that there are many reasons why patients may choose to breastfeed. And so we outlined a number of harm reduction approaches that sought to decrease the transmission risk as much as possible. In 2023, we really had a paradigm shift that emphasized shared decision-making. And instead of making a specific recommendation, we now present multiple infant feeding options. This is a shared section with the Pediatric Guidelines Panel, which is a really nice collaboration, and also was developed with extensive collaboration with many groups, including the WELL Project, which is a great resource for information about HIV and pregnancy and lactation, as well as many community members and breastfeeding advocates. And the HHS guidelines are now endorsed by the CDC and AAP. And here's what they say. Patient-centered evidence-based counseling should be offered that facilitates shared decision-making. And that should include information that replacement feeding eliminates the risk of transmission. Viral suppression during pregnancy and postpartum decreases the risk to less than 1%, but not 0. Replacement feeding is still recommended when people are not on ART or do not have a suppressed viral load during pregnancy and delivery. People who are on ART with a sustained undetectable viral load and choose to breastfeed should be supported in this decision. And this last bullet really struck me. We just heard so many stories of people for whom Child Protective Services had been engaged, and in some cases, infants taken away for people breastfeeding or even just asking their providers about information around breastfeeding. So we felt like we had to put in big, bold letters, like it is not appropriate to engage Child Protective Services around people's infant feeding choices. And so what are the data behind these new guidelines? We have about 9 observational studies from the US and Europe, including about 230 infants that showed no transmissions among patients with viral suppression. We have many more data from sub-Saharan Africa, though, where breastfeeding has been recommended for a long time. And there are at least 7 published cases of transmission where maternal viral load was less than 50 near the time of transmission. And this leads to a calculated risk of between 0.3 and 1%. Importantly, perhaps all of these were in people who started ART a little bit later in pregnancy, in the 2nd and 3rd trimester. It's not entirely clear why that predicts later risk, because some of those transmissions did occur quite late at greater than 6 months of age. And is it the case that perhaps later ART start predicts more variable adherence postpartum? Maybe. There may also be a role for cell-associated virus in breast milk, which we know can persist despite an undetectable plasma RNA and cell-free DNA and may be infectious virus. So given these low risks, though, you might ask, why would someone risk it? I think it's important to recognize there are really substantial health benefits to breastfeeding, both for babies and for mothers. For babies, these include reduced risks of things like asthma, obesity, diabetes, otitis, perhaps sudden infant death syndrome, definitely GI infections, and for premature infants, lower rates of necrotizing enterocolitis. And for breastfeeding people, breastfeeding can reduce the risk of high blood pressure, diabetes, and several types of cancer, including ovarian, breast, and also endometrial. It's also really important to consider equity. People of color are disproportionately affected by HIV and also experience a greater burden of many of the health conditions that we just saw that can be alleviated by breastfeeding. In terms of cultural considerations, people often have many different social, familial, and personal motivations to breastfeed. And we really often hear a concern that not breastfeeding will inadvertently disclose HIV status to others. Formula is expensive, and if breastfeeding goes well, it's pretty easy and can be easier than lugging around all of the material needed to reconstitute formula. But I think overarching all of this is the key principle of reproductive justice and patient autonomy. And I love this quote by Layla Pollock, who's a fantastic clinician in San Francisco, who is on our guidelines panel and also the perinatal hotline, which I'll tell you about in a minute, which says, we don't just want zero transmission. We want people affected by HIV to have the same choices and health outcomes as people without it. There are a lot of uncertainties, though, that remain about breastfeeding in the context of suppressive maternal ART. And some of these are listed here. So how long should people be suppressed before delivery in order to predict the lowest possible risk of transmission later? We really don't know. What's the optimal infant prophylaxis regimen in the context of suppressive maternal ART? Guidelines really differ on this, with people recommending anything from 2 weeks of AZT alone to 3 drug therapy throughout breastfeeding. How should people handle periods of temporary increased risk? So these might be impairments in breast health, like mastitis or cracked nipples, where blood or inflammatory cells in the breast milk might increase the transmission risk, or infant illness like thrush or gastroenteritis, where impairment of the mucosal integrity might allow for greater HIV translocation. Or it might be periods of brief maternal viremia or blips. And how can we help people navigate those? There are some options like pump and dump on the side affected by mastitis, or flash heat breast milk, or use milk stored from a previous time of viral suppression. Questions really remain about exclusive breastfeeding. Without ART, we know that exclusive breastfeeding is a much lower transmission risk than mixed feeding, but we really don't know if this is true for people on suppressive ART. And it comes up as an important question, especially if people need to fortify breast milk or supplement a little bit so that infants can meet their growth milestones. Is it okay to give a little bit of supplement? Probably, but we really don't know. And then how quickly should people wean? Again, in the pre-ART era, it was recommended to wean relatively quickly over a couple of weeks, but not abruptly. And we really don't know whether slower or faster weaning for people on suppressive ART will increase risk. The AAP recommends weaning gradually over 2 to 4 weeks, which I think is a reasonable idea. And then really important questions remain for preterm babies too, because there are fewer ARVs available, and also the risk-benefit calculation around formula feeding versus breastfeeding can be a little bit different. So despite these uncertainties, many people are developing protocols for our own hospitals to try to put into place to give some guidance when people deliver in the middle of the night. And I highlighted these two with their references below because I think they're excellent examples that could be useful to you in your own setting. I think what makes these likely to be very helpful is that they're multidisciplinary. They were developed early in antenatal care, and they're communicated to all members of the care team. And they provide really explicit resources both for patients and providers on the inpatient and outpatient side, especially for pediatricians who might be seeing these babies long-term and addressing questions like the ones I raised about mastitis or thrush, for example. So coming back to our patient, I would say C, and go for a shared decision-making and informed choice model, as most of the people on the call did as well. So I hope some takeaways from this webinar that you'll leave with are that U definitely equals U for sexual transmission. And yes, probably equals for pregnancy too, although we have lower amounts of data, but that we really can't say that it's true for lactation. But we can say that the transmission risk is very low with sustained viral suppression. Informed patient choice around the mode of infant feeding is critical. These are areas of evolving research with several remaining areas of uncertainty, but clear protocols based on our best current information can help us guide clinical care. There are many effective and well-tolerated medications available for HIV and pregnancy and breastfeeding, and we should all continue to advocate loudly for the earlier inclusion of pregnant and lactating people in clinical trials. And please submit your information to the APR. These are some of the resources that I mentioned, our guidelines, the WELL Project, the perinatal HIV hotline is available to you 24 hours a day with clinicians who staff it to help address questions. And thanks to my colleagues for slides and figures, and thank you all for your attention.
Thank you so much, Andrea. This was amazing. We have one question in the chat from Elisa Belinsky. And I think it refers to the N200 threshold for recommendation in the guidelines. And the question is, can you tell us more about the N200 threshold? And are there any specific congenital anomalies that was pegged for being able to detect?
That's a great question. Dr. Belinsky, I should defer to you on the statistical calculations. But I think that it was just to have a statistically significant difference above those general population rates. And there are specific anomalies that are included and ones that are not included. And there's a nice appendix to the APR that delineates those.
Well, there may be further questions. We want to stay on time. So if there isn't any immediate questions, perhaps you could put your questions in the chat and Dr. Ciarnella can address those questions as we turn it over to Dr. Sylvia LaCourse. Dr. LaCourse is an infectious disease physician who's trained in both internal medicine or adult medicine and pediatrics and is an associate professor in the departments of medicine, global health, and epidemiology, as well as Division of Allergy and Infectious Diseases at University of Washington in Seattle. Her research focuses on improved tuberculosis prevention, screening, and detection with a focus on persons living with HIV, including pregnant people and children. And she leads clinical cohorts of pregnant people and children evaluating diagnostics for latent and active TB infection, as well as interventional studies evaluating TB prevention therapy, including among persons who are pregnant and living with HIV and their children, whether they're living with HIV or exposed and uninfected. She was recently appointed to lead the pregnancy review group for the US-based NIH, CDC, HIV, MA, IDSA, HIV adult and adolescent opportunistic infection guidelines. And with that, Sylvia, I turn it over to you for your presentation.
Great. Thank you so much for that introduction. And it's nice to see familiar names in the audience. And I really appreciated that first presentation. I learned a lot. I think that the world of TB and pregnancy has a lot to learn from the world of HIV and pregnancy. I also wanted to mention that we're also joined today with Dr. Jean Anderson, who's the previous director of the Division of Gynecologic Specialties and professor in the Johns Hopkins Medicine Department of Gynecology and Obstetrics, and she developed the Johns Hopkins HIV Women's Program in 1991, and she's a trusted colleague of mine and long-term member of the Perinatal and OI Pregnancy Review Group. Great. These are my disclosures. So first, in terms of today's seminar, I'd like to make sure that everyone is aware of the OI guidelines and where to find them. Then we'll review a few key infections with specific pregnancy considerations, including TB and ancient disease. But we have some new short course regimens for both latent TB infection and TB disease treatment, but unfortunately still not routinely recommended in pregnancy due to lack of data. You'll see an ongoing theme here today. Syphilis, I thought I would include that because of the alarming increases in infections during pregnancy, as well as of congenital syphilis. The treatment of choice is an oldie but goodie. It remains penicillin, even in the setting of recent shortages. Additionally, I thought we'd discuss Mpox briefly due to the resurgence of Clade 1 in Central Africa. No current cases in the US, but there are specific pregnancy recommendations for both treatment and prevention. And lastly, if we have time, I'll mention RSV, which really the discussion there will be an approach to reduce severe disease in infants through a maternal immunization and passive immunity strategy. So with that, why do we need specific pregnancy considerations? Well, I'm sure I don't need to make a strong case for this group, But there's a number of immunologic and physiologic changes in pregnancy that may potentially increase incidence of some infections or the severity of other infections. Physiologic changes may affect the dosing and frequency or severity of adverse effects. Additionally, the signs and symptoms of some opportunistic infections may be masked by common symptoms of pregnancy. And then lastly, this is often complicated by the fact that we're frequently lacking data regarding drugs in pregnancy. Pregnant persons are generally excluded from clinical trials, although there is some movement there. And animal studies often do not correlate with human findings, and it also depends on what animal is being studied. And this obviously all has implications for opportunistic infection prevention and treatment. I'm going to start with one polling question just to get us all interested. And so I'm curious with this audience, have you used the HHS opportunistic guideline for recommendations regarding OI prevention or treatment in pregnant people living with HIV? Wanted to get a sense of who in our audience uses these guidelines.
The poll is up and people are answering no as of right now.
Great, then I'm glad I'm here today. This gives me an opportunity to show you where to find these. And so when you go to the homepage and you see the perinatal guidelines, on that same homepage, there's actually also a link for the OI guidelines. And you can see here, and there's the address, the website address. And what's nice is when you get to that page, you'll see a list. It's by infections, it's in alphabetical order. And they'll also tell you what's new. And so near and dear to my heart is tuberculosis. And so that's one of the guidelines that's been updated recently. And then in terms of specific pregnancy considerations, as you find yourself in those chapters, there'll be both parts of the narrative that are specific to pregnancy, as well as boxes that, if appropriate, might say if there's differences in both treatment, prevention, or diagnosis for specific infections. And so again, I really encourage you to bookmark this address, and when you have questions about OIs in general for people with HIV, as well as specifically during pregnancy. So first, we're going to start off with TB. And I thought this audience might enjoy this fun fact that there was an excavation within the last 10 years of a Neolithic woman and her infant. And this is really the first oldest known TB cases that were confirmed by DNA, and both mother and infant had skeletal changes that were consistent with TB. So I think those of us who think about maternal and child health and potentially infections in TB, this is fascinating to me. And so in terms of TB, of the 10 million new diagnoses of active TB that occur each year globally, about 33% occur amongst women, with the majority occurring during these ages that are associated with pregnancy potential. But the issue is we don't actually have great estimates on what the TB burden in pregnancy is, and it's likely high, and it's likely underreported. So we think there's about 200,000 cases of TB in pregnancy each year, but likely also an underreported. When we're thinking about TB, we're really thinking about a spectrum of disease. And astonishingly, about 25% of the global population is thought to have latent TB infection, which is really the state thought to with persistent immune responses to M. tuberculosis. But people remain asymptomatic, are not infectious, but importantly, they may benefit from latent TB treatment to prevent active TB disease. In contrast, people with latent TB infection without intervention can sometimes go on to develop active TB disease. And now people will have symptoms, they're potentially infectious, and they need treatment now for active TB disease. Our goal of diagnosing people with latent TB infection is really to identify those persons who are most likely to benefit from treatment to prevent active TB. But we'll discuss that there may be some few caveats about screening as well as treatment with regards to pregnancy. We really have two flavors of screening modalities that we can use for latent TB, the tuberculin skin test, as well as the interferon gamma assay. Pregnancy itself is not an indication for screening, although antenatal care may provide opportunity to do so. And please feel free to put in the chat whether or not in your setting if pregnant people, regardless of risk factors, are being routinely screened, because there is a little bit of practice variation. And we'll take a look at that later. So what about the timing of latent TB treatment or TB prevention during pregnancy? In low burden settings, such as the United States, for people who are at higher risk, so this is really a risk-based approach for TB, for people who've had a recent conversion of that test, either the tuberculin skin test or the interferon gamma release assay, or they've had recent contact with a person with active pulmonary TB, the idea is to treat now for latent TB infection, even if it's in the first trimester. For people who are at lower risk, and there's some nuance here, and I'd love to hear what happens in the setting that you work in, there's an idea that we may be able to consider waiting until delivery or 2 to 3 months postpartum. But again, this isn't the recommendation for people who've had a recent exposure or have had a recent test conversion. In high burden settings, the WHO recommends something a little bit different. And so pregnant people with either an unknown or a positive TB infection test, the idea is to treat now during pregnancy, regardless if they've had a known recent TB exposure or a TB infection test conversion. And so really, the idea is we have to think about the risk versus benefit. There's an opportunity to both screen and treat while people are engaged in the healthcare system, but we're thinking about timing of exposure, comorbidities. What is the actual risk of progressing to TB during this important time? Risk of side effects, etc. So TB is an ancient disease, but we've had some movement recently about exciting shorter course regimens for TB prevention and treatment for latent TB infection. And so there's a 3-month, taking pills once a week called 3HP, which includes isoniazid and rifapentine, as well as another regimen that is 1 month of taking daily isoniazid and rifapentine. And both of these shorter course regimens are associated with increased completion rates and decreased rates of discontinuation due to side effects. So this is exciting, except in these trials, pregnant and postpartum people were excluded. And so this remains a data gap. We've talked about treatment for latent TB infection. Now let's talk about treatment for people who are symptomatic and have TB disease. Additionally, there's been some exciting movement in this area. So now there's shorter course treatments for TB disease, taking now medications for 4 months as opposed to 6 months. These also take advantage of 2 drugs, including rifapentine and moxifloxacin. And so the guidelines are now changing that this is now a potential option for adults and adolescents who have drug-sensitive pulmonary TB, including non-pregnant people with HIV with CD4s above 100 on Favrins-based ART. However, unfortunately, both pregnant and postpartum people were excluded from these trials. So you'll see, although we have a lot of new, exciting, shorter course regimens, due to gaps in data, pregnant people are excluded often from these options. And so when we're thinking about latent TB infection treatment, the recommendation is still currently to use 6 or 9 months of isoniazid, and that's indicated by an H, daily for 6 to 9 months. Alternatively, 4 months of rifampin can be used. And many experts feel more comfortable or might recommend rifampin due to the reduced risk of hepatotoxicity, although now we have to weigh drug-drug interactions with many of our HIV medications, or 3 months of daily isoniazid and rifapentine, or 3 months of daily isoniazid or rifampin. So really, we're still recommending these longer courses of isoniazid for pregnant people living with HIV. In terms of TB disease treatment, we're still recommending 6 months of isoniazid, rifampin, pyrazinamide, and ethambutol. However, if pyrazinamide is not included, and previously in the US, often we would avoid pyrazinamide due to a lack of data in pregnancy. But if we don't use pyrazinamide, instead of taking drugs for 6 months, now we have to extend the course out to 9 months. So again, Lack in data and gaps in data often mean that pregnant people, including pregnant people living with HIV, have to take medications for longer periods of time for both prevention and treatment of TB. And so just as a reminder, because the data on rifapentine is limited, neither the short courses for treatment of latent TB infection nor for TB disease are currently recommended. I'm now going to move to syphilis, where we can see that maternal and congenital syphilis rates are significantly increasing. Rates amongst pregnant people have more than tripled in the last 10 years or so. And this is a ridiculous percentage, and that's why I included it, that there's been a over 700% increase in US rates of congenital syphilis in the US. The missed opportunities that have contributed to these increased rates include, as you can see the yellow stars here, a lack of prenatal care and timely testing, so lack of testing, and a lack of treatment despite a timely diagnosis. So we're going to talk about timing of screening today, as well as what are the recommended treatments. I have a question for the audience. I'm curious if people who are pregnant are routinely being screened for syphilis during delivery in your setting, because there are some practice variations there. And so all pregnant people, including people with HIV, should be screened for syphilis. This includes at the first prenatal encounter, as well as repeat screening later in pregnancy at 28 weeks. Additionally, pregnant people who are at higher risk for infection or who have not yet been screened during pregnancy should also be screened during at delivery. And then lastly, people who've given birth to a stillborn after 20 weeks gestation, the recommendation is additionally to screen for syphilis, as it may be a contributing factor to the delivery of a stillborn. So again, all pregnant people, including pregnant people with HIV, should be routinely screened for syphilis. And the preferred treatment for syphilis is still penicillin, specifically in pregnant people and pregnant people living with HIV. For people, pregnant people with a penicillin allergy, the recommendation is that they should be offered desensitization and treated with penicillin G. I won't go through this in detail, but really the answer is always penicillin, penicillin, penicillin. It depends on the what type of penicillin we're using and the dosing and how long we give it, depending if somebody has primary, secondary, latent syphilis, etc. Tetracyclines, doxycyclines, for example, are not generally recommended in pregnancy, especially in the 2nd to 3rd trimester. But I'm curious from this audience, in a using shared decision making and in a risk reduction approach, I'm wondering if you have had to have a discussion with pregnant people living with HIV about potentially using doxycycline if for whatever reason there's issues for them getting penicillin. And so I'm curious if you are having those conversations in your low barrier clinics. And again, there's really a limited role for non-penicillin regimens to treat syphilis in pregnant people with HIV. And really this comes from the WHO guidelines that if penicillin can't be used, that with caution, erythromycin could be considered, as well as ceftriaxone and azithromycin. Really important caveats, though, is neither erythromycin or azithromycin can cross that placental barrier efficiently, and therefore the newborn needs to be, requires treatment when they're born. I think also importantly is that there's high rates, and in fact, there's a letter that's going to be published in the New England Journal tomorrow that talks about near universal resistance to macrolides for syphilis in North America. So again, I think we really need to think about what are our options. Penicillin is the optimal treatment for syphilis for pregnant people and pregnant people with HIV, but I think we also have to think about to the future, what are potential options if we can't use penicillin. I'm now going to switch gears a little bit and talk about Mpox. And I thought I'd talk about Mpox just because of the resurgence in the news recently of the Clade 1 Mpox outbreak in the Democratic Republic of Congo and other locations in Central Africa that's had a number of deaths associated with it, as well as adverse pregnancy outcomes. But as of May 30th, and actually as of most recently, yesterday, there's been no cases documented of clade 1 Mpox in the US. So unfortunately, data on Mpox in pregnant people is really limited. When we're thinking about the differences between clade 1 and clade 2, which is the Mpox that was associated with the global outbreak in 2022 and 2023. Clade 1 is typically associated with higher risk of severe illness and death, high mortality rates reaching 10%, the lower in recent outbreaks, and endemic more to Central Africa. Whereas clade 2, typically less severe, high rates of survival, and endemic to West Africa. Again, there's very little data on Mpox in pregnant people. There's a nice MMR article, which is shown here. But again, this was clade 2, which was associated with the global outbreak in 2022 and 2023. Clade 1 was associated with increased risk of miscarriage, fetal demise, and there's also evidence of vertical transmission. In contrast, clade 2, there were no reports that I'm aware of maternal deaths or intrauterine infection, and adverse pregnancy outcomes were less common. Regarding Mpox prevention for pregnant people with HIV, according to our OI guidelines, Mpox vaccination should be offered to all people with HIV, including those who are pregnant, recently pregnant, or breastfeeding, who have the potential for Mpox exposure, so sort of a pre-exposure prophylaxis strategy, or following an Mpox exposure, so more of a post-exposure prophylaxis strategy. The vaccine Jynneos is the preferred vaccine in people with HIV, including those who are pregnant, recently pregnant, or breastfeeding. However, the administration of the live replicating vaccinia vaccines, you can see an example there, is contraindicated, not recommended in pregnant or immunocompromised people. Additionally, there's alternate post-exposure prophylaxis that can be offered, including tecovirimat and VIGIV, which can be considered. In terms of treatment, our recommendations during pregnancy are a little bit different for other populations. And so the treatment for Mpox currently per our guidelines should be offered to people with HIV who are pregnant, recently pregnant, or breastfeeding. And tecovirimat is the recommended first-line antiviral for this population. Lastly, I'm going to end with RSV, which is a little bit different flavor for prevention, because now we're talking about RSV prevention for infants born to pregnant people with HIV. And so RSV is a common cause of lower respiratory tract infections, typically causes mild infections in healthy children and adults. But in the US, you can see that RSV is associated with high rates of hospitalization and deaths in two important populations, children under 5, as well as older adults. In terms on data of RSV infections during pregnancy, there's a nice paper that looked at the incidence of RSV in pregnancy, and they saw it was about 11 per 10,000 US deliveries. Globally, the incidence is about 26 per 1,000 person years, and you can see there the hospitalizations. So the guidelines really reflect the data that we have around the bivalent prefusion F vaccine in pregnancy. And this is there's data to show from recent trials that this vaccine administered during pregnancy was effective against severe RSV, lower respiratory tract infections in infants, and no safety concerns were identified. And so in terms of RSV prevention for infants born to pregnant people with HIV, the idea is that for pregnant people with HIV, a vaccine can be administered between, the recommendation is typically between 32 to 36 weeks gestation in most of the continental US during the seasonal times of high transmission, September through January. However, the infant benefit is likely greatest if administered at least 14 days before delivery. At the end of this talk, I have a few key slides, and these will be posted about summary of recommendations for the 4 infections we've talked about. TB, we talked about screening, universally screen HIV care initiation, but then more of a risk-based approach. We talked about treatments for both TB infection or latent TB infection and TB disease. Really, the recommendation is still to use our longer course regimens. Treatment timing for latent TB infection for pregnant persons. People who are at high risk for progressing to TB disease, the idea is to treat now, whereas people at lower risk, you can have a shared decision-making approach and to discuss, does it make sense to wait until delivery or 2 to 3 months postpartum to reduce the risk of hepatotoxicity that's associated with isoniazid? This is a different recommendation than the WHO in high burden settings. TB disease is a different entity. Do not delay treatment. Start treatment right away. Syphilis, no real big changes in the guidelines. Universal screening in pregnancy is recommended. Targeted screening at delivery. Penicillin is really the treatment of choice, although I'm curious in your settings if you're having to have difficult discussions about using other medications. Obviously, don't delay treatment. For Mpox, we've got recommendations regarding preferred vaccine as well as preferred antivirals for all people who are pregnant, potentially also recently pregnant or breastfeeding. And lastly, RSV. This is an approach for maternal immunization to improve passive immunity in infants to prevent severe disease. And with that, I will stop and I can take audience questions, or we have a few audience polls.
Yeah, we might try, Sylvia, that was fantastic. Thank you. We may try some of those polls. I'll be curious about your thoughts. Great coverage of 4 different key areas that would be important to this group. I don't know if you saw the poll, but the majority of people said they had not used the OI guidelines.
I'm curious about that. Yeah. And so I wonder, do we need better branding? Number one. And number two, I will say there's some things that we're working about as a group. We're trying to work to be more consistent, to use boxes that really pull out key pregnancy considerations. And so if you all have a minute, I suggest perusing those chapters and see if they might be helpful in your care of pregnant people who are either at risk or may have opportunistic infections.
Perfect.
Maybe Jean, I'm wondering, Jean, do you have any comments on the OI guidelines and in your experience with the OI guidelines for pregnant people over the years that you've been part of the group?
Sure. I think it's most people know about the perinatal guidelines and they forget about the OI guidelines, and the recommendations for pregnant people is included, but it's not as perhaps easy to find. You have to scroll down for each section, and it's towards the end. And I wanted to mention just a couple of other points that I think we don't talk about too much in the OI guidelines, but one is the issue of preconception or pre-pregnancy care, because I think that the majority of the potential risk, particularly in teratogenic effects from medication or potential risk, occurs often before women may know they are pregnant, and so very early in pregnancy. And so I think it's important that providers engage women who are either for prophylaxis or treatment about pregnancy planning or even pregnancy testing in certain situations. And then I think the other thing that's going to be more of an issue for the future is lactation. We just heard from Andrea about that the perinatal treatment guidelines are a lot more permissive and using shared decision-making for breastfeeding. And we know even less about many of the agents we use to treat or prevent OIs in the setting of lactation. So I think that's something to keep in mind with, as we go forward.
That's fantastic. Sylvia's got a question up. We'll have Sylvia, you take it through, but I also see that Andrea's back on, and if you had a question for Andrea and the perinatal guidelines, please feel free to put that in the chat as well. But go ahead, Sylvia.
Great. So this, you can tell that I'm a investigator who focuses on TB because these questions are too long. But which of the following is false regarding TB and pregnant people with HIV? So isoniazid given for 6 or 9 months, so this longer course regimens, is recommended as first-line treatment for latent TB infection in pregnant people with HIV. If pyrazinamide isn't included, do we need to extend treatment out for 6 to 9 months? There's a theme here. Or C, the shorter course regimens to prevent TB disease, that is to treat latent TB infection, including 3 months of weekly isoniazid and rifapentine, or 1 month of daily isoniazid and rifapentine, are recommended for pregnant people with HIV due to improved tolerability and adherence. So which one of these is false? I will say that I didn't have time to talk about the data behind this, but I think that this is, and maybe Meryl can tell me when we get enough audience participation on this question. We currently have an ongoing trial based in South Africa, pregnant people living with HIV on dolutegravir-based ART who are receiving either 3 months, either the 3 HP regimen or the 1 HP regimen, and we're looking at safety and PK. Additionally, through the MPACT network, we're starting to have discussions about looking at the shorter course TB treatment regimens in pregnant people. So we're putting together a concept for that. So I'm hopeful that things are changing. Excellent. And so
goes in option C.
Perfect. So it looks like option C, 1 out, and that's true. That's the one that is false. B is actually true. So if pyrazinamide isn't included, we actually have to extend our treatment from 6 to 9 months typically. So again, we often, pregnant people living with HIV often have to take longer courses for TB prevention and TB disease because we don't have the data on the shorter course regimens.
Great. And Sylvia, we are at the top of the hour. This has been great to have questions for the group. If questions don't bubble through, and I think everyone has learned a lot. I know I have with both presentations. I'm going to turn it over to Maria just to do the closing.
Thank you so much. This has been amazing. I saw the polling and I wanted to click because I learned so much, but it was not allowed for panelists. I'm like, but thank you so much. This was really amazing. Just some closing remarks. Again, thank you, our presenters. Thank you for everybody for being on. Please feel free to reach out with any additional questions that you may have. I will remind everybody that the presentation will be posted online and everybody can look at it through the Harvard CFAR, and other CFARs will be shared and everybody can look at this. And then I also want to remind you that we will have another webinar in September, and it will be announced before sometime in August. So I hope everybody will join, and it will also be 2 really, really amazing topics. So thank you everybody for being on. Bye-bye.